Hello, everyone, and welcome to our module on stable angina. Stable angina is a clinical syndrome that involves ischemic chest pain that develops with exertion. So, ischemic chest pain is usually a pressure-like or squeezing chest pain in the center of the chest. In patients who have stable angina, this will develop with exertion. And then it's relieved by rest, and the chest pain has a stable pattern over time. And these three features here are very important because they distinguish stable angina from unstable angina, which I talk about in another video. In unstable angina, the chest pain sometimes is present at rest and it has a progressive or worsening pattern over time. If you do blood tests in patients with stable angina, the biomarker should be normal because there's no infarction and no myocardial necrosis. And the EKG at rest in a patient with stable angina should be normal. The EKG can become abnormal during exertion, and this is sometimes done as part of a stress test, which we'll talk about later. And the underlying cause of stable angina is a stable coronary atherosclerotic plaque in one of the coronary artery vessels. This is a cartoon of what it looks like here. There's a lipid-laden plaque with an intact cap, no rupture in that cap, and no thrombus formation. And this last point is important because this distinguishes stable angina from the so-called acute coronary syndromes, which are unstable angina, NSTEMI, and STEMI. In all of those situations, you have plaque rupture and thrombus formation. Not all patients with atherosclerotic plaque in their coronary arteries will have stable angina. Symptoms are generally absent until the plaque occludes about 75% of the lumen of the vessel. So if you imagine that this is the LAD artery here, we've got a plaque obstructing blood flow, but distal to the artery, you're going to find it branching down to the arteriolar level. These arterioles will vasodilate to keep the blood flow going into the myocardium even when there's an obstruction. And usually the arterioles can keep the blood flow normal until the plaque is occluding about 75% of the vessel lumen. The usual way the diagnosis of stable angina is made is by doing a cardiac stress test. So you have the patient walk on a treadmill like what's shown here. You are monitoring the EKG while they're exercising. The exercise will increase the demand for oxygen, and if there is stable angina, the patient will get chest pain and the EKG will become abnormal. Usually it will show ST depressions or T-wave inversions. And then sometimes we also administer a nuclear tracer that shows where the blood flow is going in the heart, and at exercise, you will see decreased blood flow to the region of the heart being supplied by a coronary artery that has an obstruction to flow. So to understand the treatment of stable angina, you need to appreciate that there's no thrombus present. It's not a thrombotic problem. So unlike in unstable angina and NSTEMI and STEMI, there's no role for heparin or antithrombotic drugs. And in the United States, stable angina is usually treated with revascularization. It's the most common indication for PCI, meaning placement of an intracoronary stent or bypass surgery. Now, you should be aware that there are recent clinical trials that suggest that medical therapy may work just as well as PCI or CABG. Nevertheless, this is the preferred modality for treatment at most centers in the United States. So this is what a typical case of stable angina in the United States looks like. A 65-year-old man develops chest pain while walking that is relieved by rest. He comes into the emergency room, his EKG is normal, his biomarkers are normal, so he's not having a myocardial infarction. He then goes for a stress test where he walks on the treadmill and he develops chest pain and EKG changes. Because of the positive stress test, a cardiac catheterization is performed and it identifies a 90% plaque obstructing flow through the LAD artery. A stent is then placed and the angina resolves. And this is how stable angina is usually treated in the United States. So as I said earlier, you can treat stable angina with medical therapy, meaning drugs and medications, rather than stent placement or surgery. This is less commonly done, but it is possible. And so to understand the different drugs we use for medical therapy for stable angina, you need to appreciate that the cause of stable angina is a mismatch between the oxygen demand by the myocardium and the oxygen supply by the coronary arteries. When the demand exceeds the supply, that leads to ischemia and angina symptoms. So the drugs we use to treat stable angina either increase the supply of oxygen or they decrease the demand. Some of the ways that we can increase supply of blood flow to the myocardium is to give drugs that dilate coronary arteries, that will improve blood flow, or drugs that lengthen the time of diastole. Remember, the coronary arteries supply blood to the myocardium during diastole. They're different from many other arteries in the body in that way. And then the four major determinants of oxygen demand are shown here. They are heart rate, contractility, afterload, and preload. And so a number of drugs used to treat stable angina target these things shown here. So the class of drugs that's most commonly used to treat stable angina is the nitrates. Nitrates are all variants of nitroglycerin, and when you administer these to a patient, they're converted to nitric oxide and they cause vasodilation. And they predominantly cause venous dilation, so they cause the venous system to swell and hold more blood than it normally would. This takes blood away from the left ventricle and that lowers the preload. One of the markers of preload is the left ventricular end diastolic volume, and it will fall after you administer a nitrate. And because there's less preload, there's less work the heart has to do to pump the blood, so that lowers oxygen demand, and that often relieves angina when patients are having chest pain. Now, nitrates also cause some arterial vasodilation, although they dilate the veins much more than the arteries. But because they dilate arteries as well, they can dilate the arterioles in the coronary system. This can increase coronary perfusion. They also can cause some peripheral vasodilation. This is going to reduce the afterload on the left ventricle, and that's also going to reduce oxygen demand. So as I said, the predominant mechanism of nitrates is to reduce the preload by dilating veins, and this lowers the cardiac output. Now, because the cardiac output falls, the blood pressure will fall, and the sympathetic nervous system will get activated. In response, the sympathetic nervous system will stimulate the heart and raise the heart rate and increase contractility. This increases oxygen demand. It's the opposite of what we want to do for angina. And so because of this effect, some of the beneficial effect of nitrates is offset by activation of the sympathetic nervous system. So in rare patients who have complex coronary disease, meaning blockages in multiple vessels, the nitrates can lower the preload, activate the sympathetic nervous system, and that in turn can cause more angina. This usually doesn't happen for most patients. For most patients, the preload reducing effects dominate, and so nitrates alone improve their angina. But for patients with complex coronary disease who have worsening angina after a nitrate, you can co-administer the nitrate with a beta blocker or a calcium channel blocker, and this blunts the so-called reflex effect of giving nitrates. So some of the adverse effects of nitrates are shown on this slide. Most of these are related to vasodilation because that's how the drugs work. So headache is very common. That's because blood vessels in the meninges can dilate, and this can lead to a headache. Flushing can occur when blood vessels supplying the skin dilate, and the vasodilation overall can lead to hypotension. And then, as I said, in rare patients, there can be angina from reflex sympathetic activation. So if you gave a patient with angina nitrate and they say their angina gets worse, it may be because of this reflex sympathetic activation. If you take nitrates too often, they can stop working. The body develops tolerance. This is more of a historical thing. Before we had good treatments for stable angina, some patients used to take nitrates multiple times per day, and they would develop tolerance. To avoid this, the patients were advised to not use nitrates continuously for more than 24 hours. Importantly, we now have a long-acting once-daily form of nitrates called isosorbide mononitrate, and this version of nitrate does not have tolerance occur. You can also withdraw from nitrates if you've been taking them for a long period of time. So if patients are taking long-acting nitrates every day and they abruptly stop the drug, they can sometimes have rebound angina, and their angina frequency will suddenly increase after they stop the nitrate. Some of the contraindications for nitrates are shown on this slide. The first one is hypotension. So as we've discussed, nitrates cause hypotension through a couple of mechanisms. They reduce the preload. They also cause peripheral vasodilation. So obviously, you don't want to give them to a patient who is already hypotensive before the nitrate. In the video on STEMI, I talk about right ventricular STEMIs or right ventricular infarctions. Patients who are having a right ventricular infarction should never receive a nitrate. So your right ventricle is very important for maintaining preload to the left ventricle. If the patient's having an infarction of the right ventricle and it's not working, they have already lost a lot of their preload to the left ventricle. So you never want to give them a nitrate to cause the preload to go down further. That could cause life-threatening hypotension. And then there are some forms of hypertrophic cardiomyopathy where there's an obstruction to outflow of blood from the left ventricle. Patients with these forms of hypertrophic cardiomyopathy are dependent on their preload, so you don't want to give them nitrates. And I talk about this in the video on hypertrophic cardiomyopathy. And then lastly, PDE5 inhibitor drugs are used to treat erectile dysfunction. They have an interaction with nitrates that can cause life-threatening hypotension, so you don't give these two classes of drugs together. And the last thing I'll mention about nitrates is Monday disease. So this is a clinical syndrome that is sometimes seen in workers at nitroglycerin manufacturing facilities. So these workers are exposed to nitroglycerin in the workplace every day, and they develop tolerance like we talked about before. But then over the weekend, when they're home, they're not exposed to any nitroglycerin and they lose their tolerance. So when they come back on Monday morning, they get Monday disease, sometimes called Monday morning headache phenomena. They're re-exposed to nitroglycerin, they get lots and lots of vasodilation, and they can develop tachycardia from the sympathetic nervous system reflex. They can develop dizziness from hypotension and headache from the meningeal vasodilation. Okay, now let's move on from nitrates and talk about beta blockers, which is another class of medications used to treat stable angina. So beta blockers block beta 1 receptors in the heart, and this slows the heart rate and decreases contractility. And if we look at our little diagram on the screen here, we talked about how nitrates reduce preload, and that decreases the oxygen demand, and that's what helps in stable angina. In the case of beta blockers, we're going to primarily decrease heart rate and contractility, but the effect's going to be the same. It's going to be to reduce the oxygen demand by the myocardium. Now, when you slow the heart rate, there's more time for diastole and more filling time for the left ventricle. This will slightly raise the preload, the left ventricular end diastolic volume. And that's bad in terms of stable angina. That will increase the oxygen demand. This blunts some of the beneficial effects of beta blockers. Nevertheless, overall, the effects on slowing heart rate and decreased contractility lead to less oxygen demand, and that's why beta blockers work, even though they have this effect. And then finally, you should be aware that beta blockers are also hypertension drugs, and that's because they reduce blood pressure by lowering the cardiac output. For angina, usually cardioselective beta-1 blocking drugs are used. These are medications like metoprolol and atenolol. You should also be aware that there are some beta blockers that are partial agonists. I talk about these drugs in the videos on treating hypertension, but partial agonist drugs have some blocking ability and some activating ability for beta receptors. The two main drugs in this class are pindolol and acebutolol. These aren't used much anymore, but in the older days, when you did use these drugs, they could actually cause more angina, and that's because they were partial agonists, so they had to be avoided. Now let's talk about calcium channel blockers, which is another class of medications that can be used to treat stable angina. So you should be aware that there are three major classes or subtypes of calcium channel antagonist drugs. There are the dihydropyridines like nifedipine, the second group is the phenylalkylamines like verapamil, and the final group is the benzothiazepines like diltiazem. And these drugs have varying properties, which we'll talk about in a second, but in general, they're either vasodilators or negative inotropes, sort of like beta blockers. Nifedipine is primarily a vasodilator. It can be used in the treatment of hypertension because it lowers blood pressure. But because it's a vasodilator that reduces blood pressure, it also reduces afterload on the left ventricle, and this is one of the things that's good for stable angina because it reduces oxygen demand. It also has some properties where it dilates coronary arteries, and this can increase the blood flow to the myocardium, and that's also good for stable angina. However, because it's a vasodilator and it reduces blood pressure, it can activate the sympathetic nervous system, just like we talked about before with nitrates, so it can have a reflex tachycardia effect, and this blunts some of the beneficial effects in stable angina. The other two calcium channel blockers, verapamil and diltiazem, are negative inotropes. You can think of these drugs as similar to beta blockers. They reduce the heart rate and they reduce contractility, and those are two of the things that are good in stable angina. However, because they decrease contractility, they are bad in patients who have a very low ejection fraction and heart failure, especially acute heart failure. So you have to be cautious of using these drugs in this situation because you can make the heart even weaker and make the heart failure worse. So on this slide, I've summarized the physiologic effects of nitrates and beta blockers. This is what you want to know for your Step 1 exam. This is what they're going to ask you about. Try not to just memorize this table, but try to understand why each item on this table is what it is. So in this column, we've got the effects of nitrates. Remember that nitrates cause reflex sympathetic nervous system activation that increases heart rate and contractility, and that's bad. That's why I've shown it in red. And whenever the heart rate goes up, the duration of diastole goes down, and so that's also bad. The only negative effect of beta blockers is that they slightly increase the preload, and then if you use nitrates and beta blockers together, you get all the good effects and less of the bad. And then this table summarizes the three different calcium channel blockers and how they work. Remember that nifedipine is predominantly a vasodilator, so it's going to cause activation of the sympathetic nervous system, which will raise contractility and heart rate and decrease the duration of diastole. Verapamil and diltiazem are just like beta blockers, and the effects shown here are the same as we saw for beta blockers on the last slide. The final medication we'll talk about for treating stable angina is ranolazine. This medication has a very peculiar mechanism of action that is not intuitive. So if you look at this drawing on the bottom right side of the screen here, this is the myocyte action potential, which I talk about in another video. And in the video on the cardiac myocyte action potential, I talk about how phase 0 is caused by sodium influx into the cell. And that's what's shown down here. Okay, if this is the outside of the cell and this is the inside, sodium comes into the cell during phase 0. Well, it turns out there's a second influx of sodium that occurs later, which is aptly named the late sodium influx. And that brings a little bit of extra sodium into the myocyte, and it can cause what's known as sodium overload. So when there's too much sodium inside the cell, then sodium will go out and calcium will come in. This causes calcium overload, which leads to high wall tension. And so what ranolazine does is it blocks this late sodium influx. Therefore, you don't get an overloaded sodium myocyte, and therefore sodium doesn't get exchanged for calcium and you don't get calcium overload. The overall effect is that this reduces wall tension and oxygen demand, and by this mechanism, ranolazine has been shown to have some benefit in patients who have refractory chronic stable angina, where other medications like the ones we talked about earlier aren't working. The side effects of ranolazine are related to blocking of electrolyte channels in other parts of the body, so you can get constipation, also dizziness and headache. And then finally, the drug has some potassium channel blocking effects, so it can prolong the QT segment on the EKG, which puts the patient at risk for torsade de pointes. Now let's move away from stable angina and talk about a rare type of angina called vasospastic angina. In this condition, coronary ischemia develops from vasospasm, and by this I mean that the coronary arteries or branches of the coronary arteries spontaneously contract and spasm, decreasing blood flow to the heart. So this is not caused by atherosclerotic narrowing like we talked about for stable angina. In fact, when angiograms are done on patients with vasospastic angina, often the coronary arteries are clean with no stenosis at all. In some other cases, the spasm is occurring near sites of mild atherosclerosis, but not the 75% obstruction that we talked about for stable angina. The hallmark of this condition is spontaneous episodes of angina. So the coronary arteries or their branches will suddenly, spontaneously vasospasm, causing chest pain that's unrelated to exertion or any other activity. This leads to transient myocardial ischemia. And usually the ischemia is significant enough that you get ST segment elevation on the EKG like what's shown here. So these patients, if you capture one of their episodes of chest pain and vasospasm, will develop ST elevations on their EKG. And this form of angina used to be called variant or Prince-Meadows angina, although now the terminology has shifted and it's usually called vasospastic angina. So the classic presentation of vasospastic angina is shown on this slide. So the episodes often occur at rest, and for reasons that are poorly understood, they often occur from midnight to early morning. So a patient who has just woken up and is having breakfast and spontaneously develops severe chest pain, that should make you think of vasospastic angina. Sometimes the symptoms even improve with exertion, which is the opposite of what we talked about earlier for stable angina. Now, this condition is associated with smoking, and this is believed to be because the nicotine can trigger vasospasm, but it's not associated with other traditional risk factors for coronary disease, things like hypertension or hypercholesterolemia. So in a board question, they're probably going to describe early morning episodes at rest. The patient may be a smoker, but won't have any of the other traditional risk factors. And in many cases, the patients are younger than what you would see for patients who develop coronary disease. The diagnosis of vasospastic angina is usually made based on history. Sometimes these patients have an angiogram, and when you're doing the angiogram, you see the vasospasm occur in the cath lab, and that, of course, obviously makes the diagnosis as well. So what are the treatments for vasospastic angina? Well, first of all, if the patient's a smoker, you should advise them to quit smoking. Sometimes that alone will make these episodes go away. And then calcium channel blockers and nitrates do have some benefit in vasospastic angina. Because these drugs have vasodilator effects, they dilate the coronary arteries, and this opposes the spasm. A couple special caveats: patients who have vasospastic angina usually need to avoid propranolol. This is a non-selective beta blocker, and it can block beta 1 and beta 2 receptors and cause unopposed alpha stimulation. And in some cases, this vasoconstriction you get in the periphery from stimulating alpha receptors leads to a trigger for vasospasm, and the symptoms can worsen. And then besides smoking, there are other well-described triggers for vasospastic angina that patients with this condition need to avoid. So these are things like cocaine, amphetamines, marijuana has been described as a trigger, and so has alcohol. Okay, the last topic for this video is coronary steal, which is a very rare mechanism of angina induced by drugs. Basically, what happens in coronary steal is a drug causes blood flow to increase to the healthy vessels and decrease to stenotic vessels. And so for this reason, blood is stolen from the diseased coronary arteries, and this leads to the development of angina. The idea behind coronary steal is that in stenotic vessels with a significant more than 75% narrowing, the arterioles beyond that vessel are maximally dilated to maintain flow. But in the normal vessels without a significant narrowing, the arterioles are not maximally dilated. This means that if you give a vasodilator drug, you will dilate the arterioles in the normal vessels, but nothing will happen to the stenotic vessels because they're already maxed out. And as a result, blood will be stolen away from the stenotic vessel to the normal vessels. So to understand this, let's imagine that we have two coronary arteries. Maybe this one is the circumflex, for example, and maybe this one is the LAD. And let's imagine that the LAD has a 90% narrowing, so there's a big plaque obstructing blood flow through this vessel, but there's no narrowing in the circumflex. Well, what's going to happen beyond this obstruction in the LAD is the arterioles are going to maximally dilate. And that's going to be done in order to try and keep blood flowing to the myocardium despite this obstruction here. But in the circumflex, there are also arterioles, but they're not dilated at all because they don't need to dilate because blood flow is normal. So what happens in this situation if you give a vasodilator drug is it does nothing over here because the LAD arterioles are already maximally dilated. But over here in the circumflex, it causes a lot of vasodilation because those arterioles have a lot of room to dilate. So the net result of this is the vasodilator drug causes more blood to flow through the circumflex, less blood to flow through the LAD, and you get ischemia in the LAD territory, and that's coronary steal. And so I've summarized these things in this slide here. A vasodilator drug is administered, the stenotic vessels have no response because the arterioles are already maximally dilated, but in the normal vessels you get vasodilation. So as a result, the vasodilator drug causes flow to increase to the normal vessels and flow to decrease to the abnormal vessels, and the result is ischemia due to coronary steal. So in reality, coronary steal is very, very rare. It's been reported in patients who take nitrates or nifedipine, but in actual practice, you'll probably never see a patient develop angina from coronary steal after taking one of these drugs. But where coronary steal is important is in chemical stress tests. So in patients who are unable to walk on a treadmill for a stress test, we will instead administer a vasodilator drug to try and cause coronary steal to detect ischemia. So the drugs that are used are uncommon drugs like adenosine, persantine, and regadenoson. These are very potent short-acting vasodilators, and they will cause a brief decrease in blood flow to the stenotic vessels via coronary steal, and this will lead to ischemia. And then we inject a nuclear tracer, and it detects the decrease in blood flow. So if you look at this drawing on the screen here, this is a depiction of the left ventricle in a nuclear stress test. So if you look up at the top here, this is what a normal left ventricle looks like in cross-section. It's all orange, meaning it's all receiving blood flow that can be detected by looking for the nuclear tracer in the bloodstream. But if you look down here at the bottom, you can see that there's this dark purple segment right here. That's an area receiving less nuclear tracer and less blood flow because of coronary steal. And so when we see that, we know the patient must have a significant obstruction in the blood vessel that supplies this portion of the left ventricle. And that's how we can diagnose coronary artery disease by a stress test where the patient doesn't exercise. It's through using the principle of coronary steal. And that concludes our module on stable angina.